Thank you. Now we move to the second talk with some practical issue about how you diagnose and the treatment men with hypogonadism. And then my outline have 4 major points. First, how to diagnose a male hypogonadism. Really, it's very difficult to diagnose and treat men with hypogonadism. And second, sexual dysfunction is a presenting of hypogonadism. And the third, testosterone therapy will improve sexual health. And the last, safety concern of testosterone therapy. And this has been addressed in the previous talk. Testosterone is produced by testes and turn sex hormone. As before, we always think it's just for sex, but now we are wrong. Testosterone is not only for sex, because 40% of men with type 2 DM have testosterone level. Now we see type 2 diabetes and hypogonadism share the same mechanism. That means the higher the testosterone level, the higher the insulin sensitivity. The lower testosterone level, the worse their insulin resistance. So now in the previous talk, we see how testosterone reverses men with hypogonadism with obesity. And clinical studies show that testosterone therapy can reverse type 2 diabetes. And this say testosterone work with dihydrotestosterone or estrogen. It controls our multipotent stem cell into all kinds of connective tissue. If we have adequate testosterone level, and this stem cell will develop into smooth muscle cell, skeletal muscle cell, cardiac muscle cell, or vascular endothelium, or our bone osteoblast, or our hematoblast. But if we have deficiency, or the stem cell will convert to adipocytes. So a low testosterone level are associated with obesity. So this is a fundamental concept regarding testosterone deficiency and treatment. This is an international expert consent resolution. Testosterone deficiency is a well-established significant medical condition that negatively affects male sexuality, reproduction, general health, and quality of life. And it may predict increased risk of developing diabetes and metabolic syndrome. You know, the most important component of metabolic syndrome is central obesity. And it will contribute to decreased bone mineral density and is associated with increased all-cause and cardiovascular mortality and negatively impact general health and quality of life. And if you have adequate treatment, will improve all these diseases. And ISSM recommend for diagnosis of testosterone therapy. The total testosterone therapy threshold is 350 nanogram or 12.1 nanomole liter. And the symptom of testosterone correspond more closely to free testosterone than total testosterone. And the clinical interpretation is confounded by wide inter-individual variability of SHBG. And the diagnosis should be made on the basis of free or variable T, even if total T appears normal. An empirical trial therapy may be offered for 6 months in a man with symptoms suggest of testosterone deficiency, but whose total or free appear normal. And treatment should be discontinued after 6 months if no symptomatic benefits has been achieved. And we recommend morning blood sampling in men over 40 years. If you're above 40 years, it's not necessary to do testosterone sampling in the early morning. And as before, we have many classification of male hypogonadism, such as primary versus secondary testicular failure. Primary means your problem comes from testes. The secondary means your problem comes from pituitary. And we have functional versus pathological, such as obesity, is a functional. Such as Klinefelter syndrome is a pathological diagnosis just for disease. And we may have very early onset or early onset or late onset hypogonadism. And late onset means in the young adults, you were normal, but due to obesity or age, you become hypogonadism. We call it late onset hypogonadism. And we may have just a congenital or acquired hypogonadism. But now we don't use this because they all are testosterone deficiency. So we just use testosterone deficiency syndrome. That's enough. And clinical symptom related to testosterone level. Testosterone symptom, three major components. First is somatic. Somatic means your muscle or your fat. Second is psychological, such as your libido or your vigor or vitality. And third is sexual dysfunction, such as erectile dysfunction or libido. Testosterone therapy is not when you have a serum normal level, that means you are free. Or if you are low, that means everything is wrong. Hormone deficiency, you may affect your decreased libido, vitality, or fatigue. That means if your patient are bothered by this, such as libido, vitality, or fatigue, you need a higher testosterone level to abolish, to improve this symptom. For men with weakness or osteopenia or loss of facial hair or erectile dysfunction, it's a severe deficiency. That means it just requires a low testosterone level, maybe enough for this symptom. And in the diagnosis and the treatment, to determine testosterone level is very important, but its interpretation is very difficult because now we divide to diagnose and treatment. Testosterone symptom lack of specificity, such as erectile dysfunction or libido. Not all the men who have erectile dysfunction are associated with hypogonadism. Not every man who has low libido are related to testosterone level. Therefore, determining testosterone level is very important in the diagnosis. And in clinical, because in precision, to figure below normal is very important. But it's not necessary to repeat all your testosterone level. Once you consider that this testosterone level is consistent with his symptom, just once enough, and you may do the testosterone therapy directly. And response to men with low testosterone level, the lower the testosterone level, the higher the response rate. And in the treatment, we need to determine their testosterone level because we may adjust their dose or frequency, and we may evaluate treatment effects, but we should consider pharmacokinetics. There are three forms of testosterone in our serum: free testosterone level, and albumin band, and SHBG. Free testosterone level is just about 2%. So it's a very short half-life, around 2 or 4 hours. It will be metabolized. So it needs more testosterone level from albumin. Albumin is loosely bound, about 38. And free T and albumin being so-called bioavailable, the parts we can utilize. And SHBG is tightly bound. It cannot be used by our body. It's just like a garbage can, but it has 60%. And factor will increase SHBG, increase obesity. And problem of determining concentration. Approximately 1/3 of men who were classified as hypogonadism on the basis of a single low total testosterone were found subsequently to have average testosterone level over 24 hours within the normal adult's normal age. That means single total testosterone level was imprecise. You need more tests. And second, study using frequent blood sampling demonstrate 50% of young normal men had total T below normal range within 24 hours. But they don't have any symptom, but they have low level. They may not require treatment. So Morgan Taylor highlighted the importance in our clinical diagnosis. You see, urologists are more liberal with treatments just based on clinical presentation. Focus his needs, such as if he has obesity or he has diabetes, he has problem of libido. You may be more liberal on your diagnosis, not rely on testosterone level. You may trial therapy. But for endocrinology, always restrict adherence to biochemical threshold. And this is not encouraged. The absence of consensus on basic questions, including who is a candidate for testosterone therapy, represent a major hurdle for the field. And this figure shows the onset of effective testosterone. It takes time. If you want to see the lean body mass, it may require 1 year. You want to see fat mass decrease, it may require 2 years. If you want to see the reduction of waist circumference, the onset or maybe 2 years. And this table to show the onset of effective testosterone and time span until the maximum effects are achieved. If you want to see the libido improvement, at least 3 weeks, at least, plateau at 6 weeks, erectile function up to 6 months, quality of life is a rapid onset, 3 to 4 weeks, depression, 3 to 6 weeks. And for lipid, after 4 weeks, insulin sensitivity needs 3 to 12 months. And fat mass, 3 to 4, this is onset, and stabilize at 6 to 12 months. And for insulin sensitivity, 3 to 12 months. And PSA plateau at 12 months. And bone mineral density, it requires 1 or 2 years. So the clinical diagnosis testosterone therapy, first, we should identify subject with risk. If he has no symptom, or if he is healthy, we don't recommend you to screen. We don't recommend. The positive rate will be very low. So we should encourage him to subject with risk. The risk for hypogonadism, obesity, type 2 DM, sexual dysfunction, male infertility, osteoporosis, aging, or fatigue. It is estimated 50% of obesity will have hypogonadism, and 40% of type 2 DM will have hypogonadism. And second step, you should determine their serum testosterone level. If both are consistent, you may go ahead to do testosterone therapy. If they are equivocal, you may trial therapy for 6 to 12 months. Now, ISSM recommends you trial therapy 6 to 12 months. After 6 or 12 months, you evaluate if there is any symptom improvement or not. If no improvement, stop therapy and re-evaluation the diagnosis. If there is improvement, you may continue testosterone therapy. The longer, the better. And sexual dysfunction is a common sign of hypogonadism. It is estimated about 1/3 of men with sexual dysfunction have gonadism. This is true with my clinical observation. And sexual symptoms include reduced sexual desire, reduced sexual activity, and erectile dysfunction, or diminished nocturnal erection. So if you rely only on erectile dysfunction, the sensitivity of diagnosed hypogonadism is very low. But if a man presenting with all these symptoms, such as he has also decreased libido, decreased sexual activity, and decreased early morning erection, the sensitivity of hypogonadism will increase. And ICSM guideline suggests that sexual symptoms are prominent presenting feature for men with testosterone therapy. Now we all know that testosterone therapy can improve general men's health, but men seldom seek treatment for his fatigue or obesity. But if he has sexual problem, he will seek medical help. Therefore, sexual dysfunction is a presenting symptom of testosterone therapy. All the society recommend screen testosterone therapy in all the men presenting with sexual dysfunction, no matter his complaint is erectile function or lack of libido, because testosterone therapy may improve libido, erection quality, and other sexual symptoms. And testosterone therapy may serve erectile function in men who have failed PD5 inhibitor. And EAU guidelines suggest that testosterone can improve body composition or mirror the sign of the metabolic syndrome and the male sexual problem, diabetes regulation, memory, and depressive symptoms. In hypogonadal men with ED, starts with PD5 inhibitor first. If PD5 inhibitor poor response, you may add testosterone. And testosterone trial, the impacts of testosterone on 7 clinical outcomes, share characteristic of testosterone trial. It can men with average testosterone level below 275, and participants receive 1% testosterone gel in a pump dispenser, and treatment allocation by minimization. And studies show that about 459 enrolled in this trial, and their mean age 72, and 90% were white, and about 9% use PD5 inhibitor. And this study to show that average overall follow-up VEGF testosterone therapy with androgel significantly increase their sexual activity versus placebo among hypogonadal men in both the sexual function trial and cross-all testosterone trial. And testosterone therapy increase their libido and a less degree erectile function. And this is their sexual function. And this is the change with the baseline for their response to PDQ-Q4. Can you complete or improve your erectile function? And this table shows that studies show that androgel therapy can improve their erectile function and libido. We are made confused for men with ED or hypogonadism. What should we do first? All the guidelines recommend PD5 inhibitor first. So what's the difference between the testosterone and PD5 inhibitor for ED monotherapy? Testosterone has an insidious onset. It may require 1 or 3 months. But for PD5 inhibitor, almost immediately, maybe half hour or 1 hour or 2 hours. And favorable responder, testosterone monotherapy only for young men with low testosterone level and mild ED severity can respond to testosterone therapy. But for ED PD5 inhibitor, all cause and all severity, even if a psychogenic or organic will respond to PD5 inhibitor. And recommendation, all the society, only when PD5 inhibitor fail and combined with hypogonadism. And for PD5 inhibitor is a first-line treatment unless there is a contraindication. But hormonal therapy can increase their libido. This is unique, but PD5 inhibitor cannot increase. And men with erectile dysfunction may associate with a lot of health problems, such as obesity or type 2 DM. And monotherapy can improve this general health, but PD5 inhibitor cannot. So there's a difference between them. And now the last portion, I will talk very briefly about the safety concern of the testosterone therapy. And physician or the general population dare to use testosterone therapy because of prostate cancer or cardiovascular concern or all sorts of cancer or polycythemia. And the guidelines, this is the latest version from EAU summary. Case report and small cohort study point a possible correlation between testosterone therapy and the onset of breast cancer, but there is yet a lack of strong evidence for the relationship. And that means testosterone therapy will not increase breast cancer. And randomized control trials support the hypothesis that testosterone treatment does not result in change in prostate histology, benign or malignant. It will not increase the prostate cancer. And present study indicate that testosterone treatment does not increase the risk of prostate cancer, but long-term follow-up data are not yet available. And there is no evidence of relationship between testosterone treatment and obstructive sleep apnea syndrome. And there is no substantial evidence that testosterone treatment, when replaced to the normal physiological range, relate to the development of major adverse cardiovascular events. And in hypogonadal men, testosterone treatment has been demonstrated to have a positive impact on cardiovascular. And this is our consensus from ISSM, from prostate. Testosterone therapy does not appear to increase the risk of bothersome voiding symptoms. It can be seen as a way to improve LUT, then worsening your LUT. And testosterone therapy does not appear to increase the risk of developing a diagnosis of prostate cancer, even if you have carcinoma in situ or prostate intraneoplasm. Testosterone therapy will not increase your from subclinical to clinical diagnosis of prostate cancer. And current evidence suggests it may be reasonable to offer testosterone therapy to selected men with a history of prostate cancer, particularly those who appear to be disease-free after definitive treatment for low-risk localized disease. So prostate cancer course can be divided to early phase, localized. In this, you may try testosterone therapy. A study to show that men who receive testosterone therapy will postpone the biochemical recurrence. But if the patient has developed to the second stage hormonal therapy, now the testosterone should be as long as possible. In this stage, we don't recommend to receive hormonal therapy. Very clear say that. And men with baseline testosterone less than 250 grams are likely to exhibit a rise in PSA with testosterone therapy. Only in this condition will rise testosterone PSA. And cardiovascular health, the weight of various indicators is not associated with increased cardiovascular risk. And the number of studies indicate testosterone may provide cardiovascular benefits because it will improve your obesity, improve your lipid and blood sugar, and this will decrease mortality. And testosterone therapy improves a number of metabolic parameters associated with increased cardiovascular risk, such as fat mass, dyslipidemia, and insulin resistance. And here is the table comparison of incidence of polycythemia between the transdermal injection of testosterone preparation. Polycythemia are easily occur in intramuscular injection form, especially the short term. But for transdermal, it's very low, although it really ever happened. All right, here is my summary of my talk. First, sexual dysfunction is a common sign of hypogonadism in men, with up to 1/3 of men with symptoms also having hypogonadism. And testosterone therapy improves sexual function, including ED, decreased libido, and sexual activity, orgasm, and poor erection quality of mind with hypogonadism. This is a unique effect of testosterone therapy in men with sexual dysfunction. And testosterone therapy in the physiological range in men with testosterone deficiency imparts great benefits to men's health by improving their cardiometabolic function sexual function, body composition, bone mineral density, and overall quality of life. And generally speaking, testosterone therapy is safe and effective when restoration to physiological level in men with testosterone irrespective of its etiology. And thanks for your listening. I'd like to answer all your questions if you have any. Do not hesitate to ask me all the questions regarding the diagnosis or treatment of deficiency. Thank you very much.
Xin mời các anh chị có câu hỏi đặt cho thầy về hai bài giảng vừa rồi.
Dạ vâng, có một câu hỏi dành cho thầy Bang Ping Jiann đấy ạ. Vâng, em cho thầy em là bác sĩ Thảo đến từ Trung tâm Hỗ trợ sinh sản Bệnh viện Hồng Ngọc ạ. Thì em có một số câu hỏi dành cho thầy ạ. Câu thứ nhất là đối với những bệnh nhân mà nam và nữ ấy, thì sự khác biệt nào mà dẫn đến trường hợp mà phụ nữ thì có cường androgen lại gây ra béo phì, trong khi nam giới lại là giảm androgen lại gây ra béo phì ạ? Và cái cơ chế tại sao mà với những trường hợp cùng là một cơ chế mà tại sao với nữ lại tăng xung LH và với nam lại giảm xung LH ạ? Đấy là câu thứ nhất ạ. Đấy, với câu thứ hai đấy chính là với những trường hợp mà chúng ta đang điều trị thì trên bài giảng của thầy thì chỉ đề cập đến phương pháp là điều trị bằng cách thay thế testosterone. Đấy, tuy nhiên thì với những bệnh nhân mong con thì dùng phương pháp đấy thì nó lại không được, nó lại hơi có chống chỉ định đối với những trường hợp mong con. Thì em xin thầy so sánh các cái thuốc, ví dụ như thuốc clomiphene, thuốc gì nhỉ? Ngoài ra là thuốc aromanta, ức chế men aromanta cũng cộng với là cái testosterone. Thì so sánh ba thuốc ấy trong trường hợp điều trị bệnh nhân có suy giảm testosterone. Và câu hỏi cuối cùng là với những trường hợp bệnh nhân có suy sinh dục, chúng ta bổ sung testosterone cho bệnh nhân, tuy nhiên thì khi nào chúng ta nên cho bệnh nhân là mãn dục nam ạ? Vâng, em xin hết ạ. Yes, the first question is that in men and women, what is the difference between the mechanism? If that when the testosterone is low, then a man will develop obesity, but when in women, when testosterone is high, then the woman develop obesity. What is the difference between the mechanism between the two sexes that cause this difference? And the case.
So sánh ba loại thuốc clomiphene, estradiol với testosterone thay thế thì ba cái này thì nó khác nhau tại vì chưa được mong con không dùng được.
And in the patients with active and want to have a child, then what is the difference between testosterone replacement therapy and drugs like clomiphene citrate and aromatase inhibitor? What is the difference when a patient wants to have a child? Then what do you use, and what is your experience on the three kinds of testosterone therapy like that? And the third question is when you treat testosterone level, when do you stop after the patient, after the andropause, when do you stop using testosterone therapy?
Oh. How many questions do you have? Two or three? Three. And first is related to the difference between the testosterone level in men and women.
That's right.
Now, obesity, sex specificity for men are associated with low testosterone level, and for women are associated with testosterone excess. The mechanism is unknown. In theory, we should elevate his estrogen to decrease his testosterone level. This is for theory. There is not any clinical data to support to use estrogen to treat male obesity. No any data. So I cannot tell you why women are associated with high testosterone and what the benefit of estrogen therapy to them. No any data support.
Vâng, câu hỏi đầu tiên của bạn Thảo thì thầy cũng nói rằng là đối cái cơ chế của hai cái sự khác biệt như thế này thì nó chưa có rõ ràng ạ, và cũng không có bằng chứng là đối với những nam giới béo phì thì chúng ta làm tăng cái nồng độ estrogen lên thì họ sẽ giảm béo phì đi ạ. Mà đây chỉ là cái cơ chế chúng ta nhìn thấy được ở nam giới và nữ giới nó khác nhau và nó liên quan đến giới tính thôi ạ. Chứ còn là chúng ta không có cơ sở để chúng ta điều trị estrogen cho những nam giới bị béo phì đâu ạ.
Yeah, but I don't remember the second question.
The second question is when a patient who wants to have a child, then we do not want to use testosterone replacement therapy. So what about the other kind of drugs like clomiphene citrate or aromatase inhibitor?
Oh. I mean, if a man wants to have baby, but he wants to have testosterone therapy, what can we do?
Yes.
First, if he really wants, there are many ways to do it. First, he may have sperm bank first, then to do the testosterone therapy with injection or androgel. And the second way, you may use clomiphene or HCG injection. Clomiphene can restore their testosterone level, but there is not any data to support such a therapy can improve his symptom. That's all. So in general, when men have baby concern, we always encourage him to have sperm bank first. Then he can go to the hormonal therapy.
Vâng, câu trả lời của thầy thì đúng là chúng tôi cũng thấy rằng là trong những trường hợp mà đối với những bệnh nhân mà có mong muốn sinh con đấy ạ, thì trong những trường hợp mà kể cả những người mà có cái nồng độ tinh trùng ở cái trong giới hạn bình thường, khi mà chúng tôi kiểm tra ở tại thời điểm ban đầu mà họ có suy sinh dục, chúng ta cũng có thể là điều trị testosterone cho họ. Nếu mà họ không ngay lập tức có nhu cầu mong con, chúng ta vẫn có thể điều trị bình thường, và trước đó người ta thường là chúng ta chỉ ngừng trước khi mà họ muốn bắt đầu sinh con khoảng từ 3 đến 6 tháng. Chúng ta ngừng cái liệu pháp testosterone đó là được thôi, thì họ vẫn có thể là trong cái thời gian đó thì cuộc sống của họ nó trở về bình thường, họ sẽ thấy khỏe khoắn và chất lượng cuộc sống nó cải thiện rất là nhiều. Thế tuy nhiên là khi mà họ gần đến lúc mà họ có nhu cầu sinh con rồi, chúng ta có thể đổi sang những cái liệu pháp khác, ví dụ như có clomiphene citrate hoặc là tiêm những cái GnRH luôn. Thế tuy nhiên là như thầy cũng nói, đó là hiện nay thì chưa có bằng chứng nào cho thấy cái việc là chúng ta sử dụng clomiphene citrate hoặc là những cái phương pháp khác mà nó giúp cải thiện những cái triệu chứng về suy sinh dục của bệnh nhân có suy sinh dục cả. Thì chính vì vậy mà chúng ta sẽ phải lựa chọn tùy tình hình thôi, và cái việc mà chúng ta sử dụng ngân hàng tinh trùng cũng là một phương pháp nếu mà trong trường hợp mà họ tương đối khó khăn hoặc là cái nồng độ họ đã thấp sẵn rồi, mà kiểu gì thì sau này họ phải sử dụng các biện pháp hỗ trợ sinh sản kèm theo. Ví dụ những người mà có OAT chẳng hạn, thì chúng ta có thể trữ đông tinh trùng trước và sau đó thì chúng ta sử dụng liệu pháp testosterone, thì hoàn toàn là rất là có hiệu quả cho những bệnh nhân mà họ có những cái triệu chứng, ví dụ như triệu chứng về béo phì này, về tiểu đường, hoặc là các cái triệu chứng về tình dục ở những bệnh nhân mà có suy sinh dục, thì đó chúng ta phải cân nhắc cái biện pháp như vậy ạ.
Yes. Yes. The other way is you may do the hormone therapy first. Forget the sperm function. Once he wants to really have baby, just stop the medication of testosterone. Maybe about 70 or 80% will have his sperm function after stopping therapy.
Yes, and how long do you stop before the? How long do you stop the testosterone?
Maybe
therapy?
if you stop after 3 or 6 months,
3 or 6
the
months.
sperm function will recover.
Yes, thank you, Professor. Đúng thì giống như là chúng tôi thôi ạ, thì thường là giáo sư sẽ dừng cái liệu pháp testosterone trước khoảng từ 3 đến 6 tháng trước khi bệnh nhân thực sự có nhu cầu mong con ạ.
Yes. Now I answer the third question. When do I stop the hormonal therapy? In fact, you should not stop the patient's medication unless he wants to. So you should discuss with your patient. The longer, the better. The longer, the better. Of course, he may stop as he wants. If he wants to stop, just stop. Let him stop and ask him to see what happened to you. When your general malaise or weakness or central obesity increased, just come back. We will start treatment again. So some patients may stop and go, start and go. And if you maintain your therapy, the longer the better.
Vâng ạ, thế cái ý này là thầy cũng đã nhấn mạnh trong cả hai bài giảng rồi ạ. Điều trị càng lâu thì cái hiệu quả nó sẽ càng tốt ạ. Vâng ạ. Thế xin mời bạn Thảo là hết câu hỏi rồi đúng không ạ? Xin mời các bạn khác có ý kiến ạ. Trong hội trường chúng ta thì còn bởi vì là cái việc mà điều trị testosterone thì nó cũng tương đối là phức tạp ở Việt Nam đúng không ạ? Bởi vì là rất nhiều những bệnh nhân mà sau một thời gian điều trị thì thường là họ sẽ do một cái nguyên nhân gì đó, có thể là do họ lười đi khám hoặc là do chi phí sử dụng thuốc nó cũng bắt đầu tăng cao rồi. Thế nên là họ sẽ thường là dừng điều trị, và chúng tôi thấy là thường là sau 3 tháng thôi là bắt đầu là có rất nhiều bệnh nhân đã không đến tái khám lại rồi. Thế tuy nhiên là cũng có một số trường hợp ít là họ sẽ tuân thủ chúng ta nếu mà cái hiệu quả điều trị của chúng ta nó tốt. Yes, I also have a question for you.
Yes.
Is that how do you what do you tell the patient to keep them coming back for the treatment adherence?
Well, so you should emphasize the testosterone contribution to your health. And the higher, the better for your health and for your obesity, for your blood sugar, for your mentality, for your vigor or your vitality. And this change may not be experienced by patient himself, but his family, such as his wife or his children, may find, Daddy or my father has some change, his behavior or his general health. Look, so you should ask your patient with open question. What do you feel? How do you feel in these months after testosterone therapy? He may change his clothes to look his younger. Really, try it. So this is the spirit of trial therapy. Let patient to have a higher testosterone level for 6 or 12 months and see what happened to his daily activity and his work performance or his exercise. Yeah. Yes.
Vâng ạ. Okay, Professor, I see it seems that
Yes.
nobody have any other questions. So
All right.
this time
Maybe
we have lunch.
Right.
If anyone have any questions, then I will deliver to you.
All right. Yeah.
Thank
if you
you.
have any question in the future, you are welcome to write to me. I like to answer all your questions. Thank you very much for your listening.